Neuromyelitis optica spectrum disorder, or NMOSD, is a rare autoimmune disease of the central nervous system characterized by unpredictable relapses, which tend to be severe and recurrent. Most patients with NMOSD have detectable serum antibodies called AQP4 IgG that target the water channel protein AQP4. In patients with anti-AQP4 antibody-positive NMOSD, AQP4 antibodies cross the blood-brain barrier and bind to AQP4 on astrocyte foot processes in the CNS, activating complement. Complement is a vital component of the immune system, comprising multiple proteins that interact in a cascade-like fashion to attack and destroy pathogens. As the complement cascade progresses, the complement protein C5 is cleaved into C5a, causing downstream inflammation, and C5b, leading to the formation of the membrane attack complex and cell lysis. Activated complement and ongoing inflammation lead to astrocyte death, demyelination, and neuronal death. SOLIRIS, eculizumab, is the first and only complement inhibitor that's FDA approved for adults with anti-AQP4 antibody-positive NMOSD. Please see important safety information and full prescribing information provided for SOLIRIS, eculizumab, including boxed warning regarding serious meningococcal infections. SOLIRIS binds with high affinity to C5, inhibiting its cleavage to C5a, inflammation, and C5b9, direct cell lysis. The precise mechanism by which SOLIRIS exerts its therapeutic effect in NMOSD is unknown, but is presumed to involve inhibition of AQP4 antibody-induced terminal complement C5b9 MAC deposition. Important safety information. Warning: serious meningococcal infections. Life-threatening and fatal meningococcal infections have occurred in patients treated with SOLIRIS and may become rapidly life-threatening or fatal if not recognized and treated early. Comply with the most current Advisory Committee on Immunization Practices (ACIP) recommendations for meningococcal vaccination in patients with complement deficiencies. Immunize patients with meningococcal vaccines at least 2 weeks prior to administering the first dose of SOLIRIS, unless the risks of delaying SOLIRIS therapy outweigh the risk of developing a meningococcal infection. See Serious Meningococcal Infections for additional guidance on the management of the risk of meningococcal infection. Vaccination reduces, but does not eliminate, the risk of meningococcal infections. Monitor patients for early signs of meningococcal infections and evaluate immediately if infection is suspected. SOLIRIS is available only through a restricted program under a Risk Evaluation and Mitigation Strategy, REMS. Under the SOLIRIS REMS, prescribers must enroll in the program. Enrollment in the SOLIRIS REMS program and additional information are available by telephone 1-888-SOLIRIS, 1-888-765-4747, or at www.solirisrems.com. Contraindications: patients with unresolved serious Neisseria meningitidis infection, patients who are not currently vaccinated against Neisseria meningitidis, unless the risks of delaying SOLIRIS treatment outweigh the risks of developing a meningococcal infection. Warnings and precautions: serious meningococcal infections, risk and prevention. The use of SOLIRIS increases a patient's susceptibility to serious meningococcal infections, septicemia, and/or meningitis. Vaccinate or revaccinate for meningococcal disease according to the most current ACIP recommendations for patients with complement deficiencies. Immunize patients without a history of meningococcal vaccination at least 2 weeks prior to receiving the first dose of SOLIRIS. If SOLIRIS must be initiated immediately in an unvaccinated patient, administer meningococcal vaccines as soon as possible and provide 2 weeks of antibacterial drug prophylaxis. Discontinue SOLIRIS in patients who are undergoing treatment for serious meningococcal infections. REMS. Prescribers must counsel patients about the risk of meningococcal infection, provide the patients with the REMS educational materials, and ensure patients are vaccinated with meningococcal vaccines. Other infections. Serious infections with Neisseria species other than N. meningitis including disseminated gonococcal infections, have been reported. Patients may have increased susceptibility to infections, especially with encapsulated bacteria. Additionally, Aspergillus infections have occurred in immunocompromised and neutropenic patients. Use caution when administering SOLIRIS to patients with any systemic infection. Infusion reactions. Administration of SOLIRIS may result in infusion reactions, including anaphylaxis or other hypersensitivity reactions. Interrupt SOLIRIS infusion and institute appropriate supportive measures if signs of cardiovascular instability or respiratory compromise occur. Adverse reactions. The most frequently reported adverse reactions in the NMOSD placebo-controlled trial greater than or equal to 10% are upper respiratory infection, nasopharyngitis, diarrhea, back pain, dizziness, influenza, arthralgia, pharyngitis, and contusion.